Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. I have been a cardiologist for more than 40 years here in the Houston area. This is one of the lectures on a series on your heart. The main focus of this presentation is what we as doctors do when someone comes to the emergency room with an acute heart attack. This is going to be a virtual tour. So what I'm going to do is to switch over to the PowerPoint and stay in the background and give you a narration of what actually happens from the time someone gets chest pain at home until they are ready to be discharged home after a successful treatment for an acute heart attack. Hello, ladies and gentlemen. Welcome to this narration or a virtual tour of watching what we as doctors do when someone presents with a heart attack. I want to introduce to you John, a hypothetical patient, 60 years old, with crushing chest pain for 1 hour, having sweating, nausea, weakness, dizziness. His wife looks at him and calls 911. As they are waiting for the ambulance, he takes an aspirin tablet and settles on the chair. The ambulance arrives at the house and they monitor his vital signs, give him oxygen, start an IV, get a 12-lead electrocardiogram, and they recognize that John is having an acute heart attack. Based on these findings, they immediately put him in the ambulance and transport him to the medical center. On the way to the medical center, they call the medical center hospital and give the report to the nurse saying, this is Houston EMS transporting a 60-year-old male with crushing chest pain for 1 hour, sweating, nausea, weakness, dizziness, pulse 78, blood pressure 160/190, respirations 14, sinus rhythm, EKG, acute anterior myocardial infarction, STEMI, expected time of arrival 10 minutes. And in the meantime, at the other end of the city, the hospital emergency room and the staff are getting ready to receive John. When John arrives in the emergency room, they hook him up to the cardiac monitor. They monitor his oxygen level, they monitor his pulse, they monitor his blood pressure. Someone will come and draw the blood, and someone will give an aspirin if he has not already taken. The doctor is there looking at him and looking at the electrocardiogram and confirming that John is having an acute anterior myocardial infarction, as evidenced by these ST elevations in the anterior chest leads. Based on this electrocardiogram, doctor concludes that he is having an acute heart attack, probably related to an occlusion of the left anterior descending artery, which supplies the anterior wall of the left ventricle, which is a branch of the left main coronary artery. Basically, the heart is supplied by two coronary arteries, namely the left main coronary artery, which divides into the left anterior descending branch, and the circumflex, which wraps around the left side. And on the right side, we have the right coronary artery, which supplies the right side of the heart and the lower part of the heart muscle. Today, we are looking at the electrocardiogram, and based on that, the doctor is suspecting he has an occlusion in this left anterior descending branch, most likely. Until we do an angiogram, we can't be sure. So immediately, John is rushed into the cardiac catheterization lab, where he is placed on the table, the X-ray machine. The nurses are getting ready. His groin has already been prepped and draped, and they are ready to do the cardiac catheterization, do the angiograms, and see if there is the critical blockage or total blockage of the suspected left anterior descending branch. As the doctors are now already got a catheter in the main artery, and they are getting ready to take pictures of John's coronary arteries, or the blood vessels that supply his heart muscle. Generally, as I said, we go from the groin, and from the groin, the catheter comes all the way into the main aorta here. From there, the catheter is placed into the left main coronary artery, and from there, we inject the contrast into the coronary arteries to light up the coronary arteries and look for the blockage. If we see a blockage like this, then we're going to proceed with the coronary intervention or stent placement if necessary. As we can look at the angiogram here, as I was telling you, the left main coronary artery divides into the left anterior descending artery and the left circumflex branch, as it is shown here. And as we suspect, there is a total blockage of the left anterior descending artery right here, right after this side branch, which we call as the diagonal branch. And here we have the septal branch, which we can see the septal branch. How do we know there's a total blockage here? As you can see, this is the normal course of the left anterior descending artery, and a large area of the myocardium that is void of circulation. So that's an indication that this artery is blocked off right after the origin of the diagonal branch. Now the mission for the cardiologist is to get a wire across this blockage and try to open up with a balloon, and it is shown here diagrammatically. A wire is passed through the totally blocked artery, and it is advance beyond the blockage. Then we take a plain balloon to start with and compress this plaque. After that, that balloon is removed, and a second balloon with a stent mounted on it is placed at the region of this blockage. And as you can see, when the balloon is expanded, the stent sort of plasters to the arterial wall, thus compressing the plaque and increasing the lumen. With this, we expect the circulation to be re-established in that totally occluded left anterior descending artery. And as we can see, here is an expanded version of the balloon with a stent mounted on it, which has been expanded in the totally occluded artery, thus opening up the channel. And as you can see, an artery that was totally occluded with a faint thread going on after the balloon. Here's a wire, guide wire here. After they did the plain balloon, they could see some faint visualization of the artery, and after the placement of the stent, you can see the arterial blood flow has been re-established, and there is a wide opening of the artery. At this time, the doctors ask, "John, how are you doing? How is your pain feeling?" John may say, "I'm feeling a little better, doctor. Thank you very much." John, as you can see on the monitor there, your artery was totally occluded, and we were able to get a wire across the blockage. And here's a stent. You can see the markers here. And we have placed a stent and re-established the circulation in your coronary artery. And we are very pleased with the results. And we also see your electrocardiogram is showing improved changes after re-establishing the circulation to the left anterior descending branch. After that, John is transferred into the intensive care unit or monitor unit with intravenous fluids. He will be alert, and he will be talking, and he will be started on blood thinners. The family can come and visit him, talk to him, and the doctors will explain to the family as exactly what was happening in the cardiac catheterization lab. If everything goes smoothly and easily, the procedure may last for an hour or so, but if there are technical difficulties involved, it may take 2-3 hours. Whenever a patient is prepared for a cardiac catheterization and emergency stent placement, there is always a consent obtained for possible emergency coronary artery surgery. In case the artery doesn't open up, or if there is any technical problem or issues dealing with the opening of the artery, then the patient may be sent for surgery depending upon the location and number of arterial blockages. Once the patient recovers, once he is on the regular floor, we may do an echocardiogram to look at the heart size, the heart muscle function, heart valves, blood flow across the heart valves, and they may talk to you and mention something known as the ejection fraction. That is the amount of blood the heart is pumping compared to the amount of blood it received before it started squeezing. an ejection fraction of 55 to 70% is normal, and due to the damage to the heart muscle, your ejection fraction may be slightly less, but it may improve with the time as the heart muscle slowly recovers its function. Once this is done, the nurse will come and give you all the instructions about all the medications you should be taking. They are also going to give you instructions about diet, about progressive exercise under medical supervision, controlling weight, controlling blood pressure and sugar. If you have any problems, you may also be started on blood thinners and also on cholesterol lowering medications. And it takes a team of people to really do this undertaking, starting from the EMS team to the emergency room staff and people involved in the cardiac catheterization lab, and so many people involved on your post procedure. It takes a number of people to get you back to a functional status. So ladies and gentlemen, it's time to go home and start the slow recuperation. But this is going to be a life transforming experience, which any person you can talk to will tell you, and it will change their whole perspective of life for good. And that will hopefully be a great learning lesson for each and every one of us who are overweight, who are smoking, who has history of hypertension, diabetes and high cholesterol, to take care of these problems before you get a major incidents like this, which can be quite stressful. Thank you so much for watching this presentation. Hopefully this has sort of increased your awareness of the gravity of the situation. If you or someone else is having chest pain, that could be the sign of a heart attack, and what steps need to be taken to make sure that person gets immediate and appropriate treatment. We have a series of lectures on public education about you and your heart. Please do watch them, and I will see you in the next video. Thank you so much for watching this presentation.